We welcome you all on behalf of ISAR, Mumbai ABGY Society, and supported by Mayor Vita Biotics, to a special occasion, World IVF Day. Well, it has been 46 years to Louise Brown's birth. It has been 46 years since 25th July 1978, the first IVF baby. And I think we should take a moment to remember Dr. Robert Edwards, Dr. Patrick Steptoe, and John Purdy. Well, this day definitely marks the victory of a process. It marks the victory of technology. It marks the victory of faith and perseverance. It marks the victory of innumerable struggles that a couple undergoes while they are going through the process of IVF. And as they say, there is light at the end of the tunnel. We as clinicians, we as practitioners strive to get to that light, to give that woman the positive beta HCG, to give that woman the take-home baby. And that's what we are here to celebrate, World IVF Day. I would take the opportunity to thank our President ISAR, Amit sir, for giving me and Garima this opportunity to be here with you as Masters of Ceremony. And I would like to call upon sir on stage to just express his thoughts on the importance of this day and why we are here today. And then we can take the proceedings further. Welcome, sir.
So, a very good evening to you all, and I think I need to thank you from the bottom of my heart for coming and maybe wading through some of the floods around. But today is a very important day for fertility specialists, not only because it is Louis Brown's birthday, because I think that broke a lot of myths that were there associated with IVF. And if you actually read the book explains how much of ostracization Louis Brown's mother had to face once she was born. The Church of England and various other religions actually condemn this process, saying that it is an act against God. And here we are 46 years later actually celebrating the very thing. So I think it needs a lot of courage to be the world's first, and in this case, certainly so. And the last 46 years, I think we have seen tremendous advances in fertility treatment. And I think we have only our patients to thank, because they put their trust in all the procedures, innovations and technologies and the drugs that we offered them to only fulfill their dream of parenthood. So I think this day we also need to celebrate our patients, because they are the ones who put their trust, their lives, as to say, to try something very new. So, welcome to World IVF Day, and I would like to ask the Master of Ceremonies, Dr. Siddesh and Dr. Garima, to take the proceedings ahead. I would also like to thank Mayor for coming up wholeheartedly to support us in this event. Thank you, Mayor.
So without much ado, we can start with our agenda for the day. Our first session is a panel discussion on maternal aging in infertility and pregnancy. And for that, I would like to call upon our moderators. Dr. Pratik Tambe, sir is an ERT consultant, gynec endoscopic surgeon at Ashirwad IVF Mumbai, and trained in assisted reproduction at Belgium. Was the chairperson of EMOG's Endocrinology Committee 2022 to 2024, Governing Council member ICOG from 21 to 23, Managing Committee member of MOGS, ESAR and MSR, with numerous prizes and publications to his name, and our mentor as Youth Council members, two junior Managing Committee members of Mumbai OBGY Society. Welcome, Dr. Pratik Tambe, sir. Our second moderator is Dr. Rohan Palshetkar, who will be joining us soon. I would just introduce him in brief. He is the chairperson, Foxy Young Talent Promotion Committee, professor at D.Y. Patil School of Medicine, managing committee member of MOGS and MSR, and an awardee of numerous awards to his name. Welcome, Rohan, whenever you are here.
Let me begin by thanking ISAR, Dr. Amit Patki sir, the office bearers of ISAR as well as the Mumbai Society for giving me this opportunity to be here on this prestigious World IVF Day to tackle a very important issue, not only as far as infertility is concerned, but also regarding pregnancy and high-risk pregnancy very specifically. We will have Rohan on stage as and when he comes in, but I'd like to begin with the introductions of the panelists. Dr. Nandita Palchetkar is a past president of FOXY, ISAR, IIG, Mumbai Society, and we hope that she will be able to join us shortly. I believe her flight is delayed. Dr. Rishma Pai is on the way. Again, she has also been a president of the Mumbai Society, FOXY, and ISAR in the past. We have with us Dr. Sudha Tandon, who is the director of Sudha Tandon Fertility from Chembur, and we know her as one of the office bearers of IIG, that's our Indian Association of Gynecological Endoscopists. She's also a renowned IVF specialist in her own right, and she has two budding daughters who are youth council members of the Mumbai Society, and under her tutelage they are coming up very well. Please take your seats on the stage. I'd also like to welcome Dr. Suchitra Pandit, past president of FOXY and Mumbai Society. I know that Dr. Suchitra Pandit doesn't require any introduction to this audience. She is well known for her views on pregnancy, sexual reproductive rights. She is going to enlighten us regarding what are well known for academics and especially as far as obstetrics and infertility is concerned. Okay. Yes, I was just so our very first set of questions are specifically regarding infertility practice. And I wanted to start by asking Dr. Sudha and Dr. Rajkumar could take this up. Are we seeing more and more women of advanced maternal or I'm going to get dizzy now. Okay, let's get the ball rolling. Next slide, please. It's okay, you can change the slides. I don't think it's okay, this one. All right, perfect, it works. So after those teething troubles, let's start by asking, are more and more women of an advanced age presenting for infertility treatment? Dr. Sudha, you have experience of at least 30 years as far as obstetrics, infertility practice is concerned. Do you think that the women who are presenting for treatment today are of a very different age group, different socioeconomic background as compared to when you probably first started practice?
I think this is a reality. This light is on my
We can use one of the other ones perhaps?
Yeah, for various reasons, we see lots of women coming at a very, very late stage. I mean, surprisingly, these are the women who are educated and somehow they know everything, they may know everything about fertility and the problems associated with maternal age, women's age and fertility, but by the time they come to us, surprisingly and realistically, it is very late, and generally it is beyond 35 to 40. Sometimes even 42 and 44 is when they come. And there are various reasons, associated because of which they come late.
Perfect. Dr. Rajkumar, would you say that today the goalposts have moved? We find that more and more women are putting off childbearing until later on into their reproductive lifespan. They don't really understand the implications of that postponement. But could you take us briefly through this entire situation as it stands?
Basically, I do agree that we encounter a lot of women coming as compared to the earlier years as such, that they are much older as such. Maybe the reasons are possibly that they focus more on education, career, and then there have been options given by companies where they think of egg freezing, so they come directly for egg freezing, Besides that, I don't know, but I would just like to concur with others whether they are seeing second marriages now.
Yes,
and
that's
women
an
with
important
an elderly
reason.
age group.
Yeah.
So this is
That
an age group.
Yeah, sorry.
Yeah. So this is the age
Second
group.
marriages, yes, but I think more than that, it is the economic factor, or
Yes,
also the
very
thing they have
important.
to settle in their career, they have
Very
to
good.
settle getting giving the loans.
Because of the high cost of living in
High
Mumbai,
cost of living in
it's very
Mumbai,
difficult
yeah.
to save up enough money
Yeah.
to think of affording a
Yes.
child.
And family support is something which they really, by and large, do not have. Secondly, I think nowadays there's a lot of women, because of COVID, who could not get pregnant, that
Yes.
they're coming. So, I mean, today I had a patient of 39,
Multiple reasons,
39 years old. I was thinking, what happened? Why have you come so? No, COVID just, because they were not well paid, and all those reasons. Because of that, 2 years they have lost, which is a big
And I
thing.
think also
Yes,
it's a peer group apart from the economics, the peer group, because people the adolescents have a peer group pressure of doing something.
Yes,
There is
very
no
true.
my colleague is not yet got a baby, so I don't think it's important to have a baby. So the peer pressure is like a fashion to have a child late.
Dr. Vanita Raut
Second
wishes
thing,
to
more
take-
than economics, I think they are more career oriented.
Very
They
true.
have to climb up the ladder, though not actually. There is a subtle discrimination. If you are married, if you are going to get pregnant, there is a subtle discrimination. Plus, I think now that the options are available of egg freezing, and there are certain companies which do support them. No, they financially. So since the option is available, I think they are going for it.
I remember once upon a time reading somewhere, I forget exactly what publication it was, but it was probably a fiction work, which said, and very narrow misogynist patriarchal view, that women keep getting married and leaving to have babies, so probably we should not appoint them into higher positions. I don't think that's something which we even consider in today's world. Dr. Mohan Gadam, what would you think? Women have broken the glass ceiling, they've reached the moon, they're on the International Space Station. There is no place in today's world for this kind of narrow-minded behavior.
Right. I think fertility and baby has become a second priority. Amongst the educated class, they want to settle down, they want to have fun in life, they want to have enough money. I think we've had patients coming at menopause. Oh, now we are settled, we want to have a baby. That's something which is, extreme of it. And more and more people, we are getting much more number of poor responders than earlier.
I'm glad you brought up that word poor responders, because the very next question is regarding this. And I want Dr. Rajkumar Shah sir to take this up. Can we also have women who are poor responders at a younger age? And by younger, I mean less than 35 years, because that is typically the watershed that we consider between elderly and younger as far as fertility treatments are concerned.
Yeah, so of late, we've been seeing this. Maybe we are more conscious, maybe AMH has come in practice, and therefore we are picking up more number of patients as such. But yes, we are definitely encountering more number of poor responders. Poor responders would be patients who have tried somewhere else and then come down to us, where primarily we have picked up them as poor responders. But yes, there is definitely an increase in the number. No
Thank you,
question.
sir. Dr. Sudhanandan ma'am, would you agree that if I said that reproductive aging, in inverted commas, occurs maybe in an Indian population much earlier as compared to a Western or a Caucasian population? Is that something which we are noticing now?
Yeah, I think you're quite right. You're perfectly right. We are seeing a lot of Indian women coming with a poor ovarian reserve at a much earlier age, sometimes even 30, 31. So it's not really 35, even 30 to 31. And some of these women, they don't get diagnosed as premature ovarian failure.
Just like endometriosis diagnosis can
Yes,
take
so-
7 to 9 years.
Yeah.
Poor responders also typically is a
They
diagnosis
don't
which
get
is quite
diagnosed
delayed.
earlier, and they may not be married, but they have some issues. They go to a gynecologist, but they do not get diagnosed. I know of at least a couple of such women who are not married, and they had a lot of menstrual issues, and finally they had premature ovarian failure at the age of 25. So I think that is something which one needs to be aware of.
Yes, one needs to be.
The lifestyle changes have occurred significantly in this last decade. I mean, apart from having PCOS on the rise, endometriosis, the general lifestyle, erratic eating habits, stress of work, running around, not getting time to relax and working maybe 18 hours out of 24. So lack of sleep and all these things also contribute to the poor ovarian.
They compound an already poor situation. Dr.
Absolutely.
Mohan, would you agree that expected poor responders are very different from unexpected poor responders? But before we go into that, could you tell us what is a poor responder? Is there any classification system for that?
Yeah, poor responders mean the ovarian reserves to be, I mean, in simple words, the ovarian reserves are less. They have a low antral follicular count on day 2 scan, and their AMH values also are less. So two together you can put them into category of poor responders, either mild or severe poor responders, where the AMH is less than 0.6 or 0.8 and less than 0.1 and more than 1.1 and less than 2. So there is a
So
classification
primarily
which
we
has been
look at
put
the
in
antral
place.
follicle count on a baseline scan. We would look at the serum AMH values, and most importantly, we would assess the response to a previous stimulation.
Yes.
And in a previous conventional proper stimulation with good dose of HMG or FSH, if you have 3 or fewer oocytes retrieved, that is what is pathognomonic of a poor responder.
Yes, that's true.
Dr. Rajkumar sir, would you think that in today's world, especially in Mumbai city, with so much pollution, are we being exposed to a lot of construction, VOCs, pollutants in food, air, water, all around us? One effect of that is, of course, premature graying and aging. So I'm pointing to myself here. But also it has a lot of harmful effects as far as fertility is concerned, notably the endocrine disruptors, what you call. Would you agree?
I do agree that probably these are something which we have come to a conclusion. Possibly these are the things as such, but there's no study which has been done which definitely tells you as such. But yes, we can always think about such possibilities. Construction is happening day in day out. Railway bridges, the flyovers, then
Metro
the
construction.
whatever you say, so all these things is happening, plus construction of new buildings and other things. So demolition and construction. So all that is adding to the pollution, no doubt about it. But we do not have a definite factor saying that this pollution is responsible for fertility problems as such. I'm sure at the back of my mind, I'm quite clear that it is possible. But yet we do not have data to say that definitely this is the cause as such,
Especially when you consider plastics and bisphenol and BPA and all the pesticides that we eat. There's no organic food left anymore in Mumbai city. We are all eating stale and frozen vegetables. We are probably exposed to a lot of pesticides and chemicals. And that may also be one of the reasons why there is plummeting sperm counts with very poor motility, very high abnormal forms, and also these poor ovarian responders as well, which we are seeing. Let's quickly go to the modifications that we can make during the stimulation process when we are dealing with a known poor responder. Dr. Sudha, do you want to take that up? Is there anything that we can do before we start the cycle, during the cycle and after the cycle? Let's address the pre-treatment part first.
Yeah, so before the cycle, there are lots of adjuvants, lot of antioxidants, which you could use, but most important is to remember that these have to be used for at least 3 months.
Very good.
Before you, before you plan a oocyte pickup or a stimulation protocols, because that is the time it takes from the primary oogonia to the mature oocyte, and that is true even for males. So I think one must remember that we can't just start that and start the stimulation in the same cycle. So I think that pre-treatment is extremely important. Modifications, there are lots of things which are there in the literature, but I don't think there is anything that you do this and you will definitely get. So I think that
Your mileage always varies.
yes, so I think it's you can try various things, especially using of testosterone, the gels which are available.
Yes.
DHEAs, I have not found big results, honestly, even if they've,
So
because there are
androgens-
lots of patients who come to us who are already on DHEAs, even by the general practitioners who started them on.
So androgens is one class of
androgens
drugs
is
which we
one.
have been using. In fact, it was the only thing available to us 10-15 years back. Now, of course, as you mentioned, there are transdermal gels which are available. I would like Dr. Mohan Gadam sir to tell us a little bit about the other classes of agents which are available and which are to some extent at least evidence-based. They are not entirely experimental therapy.
Meaning adjuvant, that is what.
Yes, sir. Yes, sir.
We
Mitochondrial
have-
rejuvenators, ovarian rejuvenation.
Yeah. CoQ is there.
Yes,
in
coenzyme
high doses
Q10.
CoQ, which probably can rejuvenate. Aneuploidy goes down.
Yes.
It has to be given for a long time before you actually see the results. And often these drugs come and they go, and we realize that it's not of much use. So this is what has been happening for most of the things. Like DHEA came in market almost, I think, 10-15 years back. And even today, after 15 years of use, people are saying it's not of much value. So I don't know, but
It varies from
I
patient to
found-
patient, I suppose.
But you need to try. In any case, you need to try. And a young patient or a poor responder comes and she is willing to take this drug. You can try this, wait for some time. And I've seen pregnancies with DHEA, spontaneous pregnancies with DHEA. Testosterone is another drug which probably has some recommendations in the literature also. So you give transdermal testosterone for 1 or 2 months, and then certain things while stimulating the patient. So you go as per the poor responder protocols, DOR protocols, like you can add growth hormone and
Yes. So there are
then-
multiple modifications you can make
Yes.
during
So
the cycle as well.
probably
Dr.
I think
Suchitra madam has raised her
everywhere
hand.
I just wanted to mention one thing. You know, it's akin to tilling the soil, cleansing and tilling the soil. So the same way it would apply to anybody who's wanting to come for a pregnancy, maybe she's an older woman. So unless you cleanse her system, detox her system, and maybe give her adjuvants. I mean, I'm not just talking about vitamin D and vitamin B12, but like a wholesome change in the structure, it has made a difference. It may not be statistically significant as per papers, because for that, you have to have a big sample size. But from whatever we have been seeing, changes in the lifestyle and, those things certainly make a lot of difference.
They do have some impact
I
at
think in
least.
the lifestyle, reducing weight really helps.
Thank you. That's very important for us to note, especially today, when we have so many endocrine disruptors, we have so much fast food, and when we have so much easy access to those drugs and those foods which always give us dopamine hits, it's very difficult to resist them. Dr. Rajkumar, so let's come back to the entire issue of reproductive aging. Would I be correct if I said that in a woman who has reproductive aging, the chance that she will produce an aneuploid embryo is significantly higher, and that is one of the important treatable causes for getting a good success rate as far as our ART treatment is concerned?
Yeah, I do agree that aging would definitely contribute, and that's the reason why there is a general suggestion to all patients that try and conceive before the age of 40, so that we try and avoid
But
possibilities
we can't
of
say that.
malformations.
That
Yeah?
wouldn't be politically correct.
Sorry?
We can't say that.
No, but this is what we encourage for. Okay. The general idea is that we encourage them to conceive before the age of 40,
Yes.
with the fear that there's a possibility of abnormalities coming up. Aneuploidy is just one of them as such, but there may be many more problems as such. So therefore, as a wise old man probably would suggest, yes, go ahead and conceive before the age of 40 if it's possible as such. Yes, these worries are there about aneuploidies, and of course you do have PGTA to find out whether such a thing is there or not, but there's such more said than done as such. Very commonly if it's to be practiced, it may be a little difficult.
So if I can ask Dr. Mohan Gadam sir, whenever we talk about poor responders and modifications to Poseidon and protocols, etc., we always talk about the number of follicles or oocytes that are required to produce one euploid embryo. This is a very important, how can I put it, counseling that we can do for our patients so that they have a realistic view of what to expect at the end of our treatment? Could you
Yes,
highlight
right.
that?
I
sir?
think it goes in the proportion of 4:1. So if you have 4 aneuploid embryos, probably have one single embryo, which is this thing. If you have facilities and if you have availability of certain things, one should go ahead with selection of an embryo, take a euploid embryo and go ahead with a single euploid embryo of day 5 transfer. Probably that will give you very good results. Otherwise, quite often beyond 35 years, everything goes well, quality of embryo is good, endometrium is very receptive, endometrial thickness is very good, and often land up with failure, and quite often it is probably related to aneuploid embryos.
Thank you, sir. Dr. Sudharpan, ma'am, would I be correct if I said that out of maybe 14 or 15 follicles or oocytes in an expected poor responder, typically Poseidon 4, more than 35, AMH low, AFC just 2 or 3, would I be correct if I said that 14 or 15 oocytes or follicles are required to give one euploid embryo?
14 to 15 follicles giving one, but how many eggs?
Approximately more than 10, because not all follicles will give you.
Yeah, but you will not get 14 to 15
That is the whole
follicles.
issue. That is the whole issue.
Yeah, you will not
In
get
one
14 to
stimulation you
15
won't get.
follicles in these women of Poseidon 4. You would just, if you're lucky, you'll get 4, 5, but the number of eggs would not correspond to the number of follicles. Even if you get 1
And
or 2.
therefore you need to pool these
and then you
embryos?
need to pool, and this is what you need to tell right in the beginning. That
And-
you need to counsel them that one cycle, don't expect miracles.
It's a long process.
It's a long process.
It requires
Yeah.
time, patience, a lot of investment mentally
Yes,
and
so
financially as well.
mentally and
14,
financial is where this
14,
is
15
what.
is probably not allowed in today's ART law. So probably we have to cancel the cycle if you get 14, 15.
So basically, this is all age dependent, and before the Poseidon criteria came, they did a workup and showed that below the age of 35 you require 8 good eggs, beyond the age of 35 to 40 around 11, and above the age of 40 20. So if you have that many eggs available, probably you could have one euploid embryo.
And we'll just close this discussion. This has been addressed, of course, previously by our panelists. But how much should we be encouraging in our role as educators and advocates? How much should we be encouraging women to freeze their eggs in today's climate? Everybody and anybody can contribute, please.
Yeah,
Always.
I think
I think-
majorly. You tell them this is just like an insurance, you're keeping something in the bank. It's not that you would use it, but there's a possibility that you might use it. If you get a partner somewhere, early, then you can have a natural conception, but at least this will take off the pressure of your load
But the key
on
is
your
to
head.
talk to lay public, not amongst us in a closed door.
Yes.
As long as we are doing this advocacy, it has to be for lay persons in corporate sector, especially who will probably have that kind of support from their institutions.
Quite a few of them are coming voluntarily. They are coming voluntarily about inquiring about the egg freezing.
But again, I think I have a very strong opinion about this. I think we have to give a general counseling. Just because it's available, don't go into it. Just because in a corporate, don't go into it. Ask them why don't they want to have a child. Counsel them about that. Many of them would agree. And then think about it. Just because it's in fashion, it shouldn't be done. Because many of the girls they want to come and do it just because it's available and they can afford it.
I don't think nobody should do it for fashion. There's no question about that. One who is contemplating a late marriage, late pregnancy, you must, whichever class that patient belongs to, probably you should counsel them for egg freezing.
It is
and,
not,
And
yeah.
I think amongst all these procedures like poor responders, management of poor responders, pregnancy outcomes in poor responders, use of antioxidants and all that, if a young eggs are available, I think that will really suffice. That will give the best results probably.
So pausing the fertility clock is probably the best treatment that we can offer at this particular juncture. It works better than any mitochondrial rejuvenator. But when you don't have that option, then you need to look into all these other
Yeah, it's
options.
not really for fashion, but these are the women who have not got they don't have a partner. They've not found the right partner, I would say. So then what do they do?
So I
do they
think
just
now
wait till
they are
eternity,
running out of-
till they get and then they're already 35, 36, or I would say freeze your eggs at 30, 29, 30.
We
and
are
then
running
at
out of
least-
time, so we need to move into
One more thing.
pregnancy
You
and
can-
high-risk pregnancy part
if-
of the discussion.
Either egg freezing or embryo freezing. If there is a choice available, one should go for embryo freezing. Because
that.
as of today, obviously the results are better with embryo freezing.
True that. Now, this is a very important distinction which I think everybody needs to make, and it needs to be understood, especially by those of us who are there, watching, listening, and who do not practice ART. And I can't think of anybody better than Dr. Suchitra Pandit to answer this. Is there a difference between an elderly primigravida, which we read about in our Oxon food days, a post-ART conception primigravida, who may not necessarily be elderly, and the worst possible combination, both? How do they differ in their presentations and incidence of complications?
See, I think basically today the concept of elderly primigravida, the age has changed. We used to think of 30s a decade ago. Now we are saying 35 plus, even 38
Everybody's
is still
35 plus.
anyone. Hey, you're okay. So that word elderly primigravida has gone away. Now, we used to always think the older you get, you're going to have a worst outcome of pregnancies. That's not strictly true. But the general rule is as you're growing older, your quality of eggs is definitely going to change. You're probably going to have comorbidities like maybe, putting on weight, diabetes, hypertension, endometriosis or fibroids. I mean, those are the core things that are going to come along. And conception is going to become more difficult. But if they've already conceived and come amongst these three groups, amongst all these three, if my elderly primigravida, so-called 35 plus, if she's not got any comorbidities, I think she would go through, but with vigilant monitoring. Because again, I'm still worried about the GDM and the hypertension. That's more common. But with the post-ART conception, in fact, one of my students had done a thesis and we had some 100 cases post-ART. And you will not believe, there were hardly 3% who went comfortably to 38 weeks.
And they could also deliver vaginally.
And they could deliver vaginally, but otherwise, most of them, particularly where it was an ICSI pregnancy. I know many pregnancies are ICSI even in a normal, with no problems with the male.
With good sperm counts.
But when they've had a complicated IVF and then they've come, invariably the problem they have is miscarriage rates are higher. Now, if they've come to me after their first trimester scan, the os opening up, that is another problem, particularly if they are twins. And later on, the problems of preterm labor, PPROMs, preterm labors are in fact, PPRMs, very funnily, 33, 34. And that was, of course, the fetus
Very
is
close to
salvageable
pulmonary
by
maturity.
that time. But now when you're looking at elderly priming, post-ART, that's the worst combination. Because then apart from all this, there is something that tells you. But there's a very interesting paper which has come from Stanford, Julie Cohen. She says that the older women with ART are looked after better. They probably have more antenatal visits, more ultrasounds, more fetal medicine interventions, better care and more fetal surveillance. So their outcomes are better. So, now the problem is if they are looked after better. So you really have to know what is optimal care for this particular group of women.
So we're
and they
coming
will.
just to that.
But you cannot have just a routine antenatal care for the second two.
Absolutely. That's exactly what I'm coming to. Dr. Vanitha Raut, ma'am, today we talk about inverted pyramid of antenatal care, where the maximum visits are diametrically opposite to what we were taught when we were medical students. Does that inverted pyramid of care also apply to these ART pregnancies? And to what extent would that be correct?
Definitely. I think after the first, most of the times they come to us when the first trimester is over, because these people refer to us when the trimester is already over. But instead of doing only the NT scan and double marker in these elderly patient, probably you will go directly to the NIPT rather than doing double marker, or I'll go to one extent, do the double marker, because it's going to predict the IUGR, the PIH, etc. and also do the NIPT at the same time, because then you're not wasting the time. Otherwise, double marker, then NIPT, so you're wasting almost 3 weeks or so. So, your question was how,
Basically,
yeah.
yes. How would
Then
you,
maybe
what would be the
if there's
ideal
any doubt,
surveillance
I will
pattern?
like to do a early anomaly scan at 16 weeks. not only for the aneuploidies or not only for the structural. See, these are the patients, almost I think 60 to 70% of patients who have undergone the ART treatment have undergone a hysteroscopy, lateral metroplasty, and we have seen that the cervix does start opening earlier. So unless you are looking out for it, you are not going to pick up. And if you wait till 18 weeks, 20, suddenly at that time you see that the cervix is already open and the membranes are bulgy. So maybe we have to be more actively looking out for a opening of the cervix and take the corrective measures. So one is screening for the aneuploidies. Second is looking out for the opening of the cervix. Structural, I don't think there will be much of a difference between the person who has, if they already passed the first trimester. So structural, the incidence probably will be more or less same. So early anomaly, maybe NIPT, and
Dr. Suchitra.
Can I just add on? I
Yes,
would do
ma'am.
the Gestosis score every
Thank you.
for these
I was
patients.
just going to come to that.
Yes,
GDM
because-
screening and preeclampsia screening.
And because, we do the Gestosis score, of course, the very fact that their ART gets
2 points.
straight away. And then the age gets another one. So they're already 3+. So they're, as it is with IVF, they're on ecosprin. But then when you're doing
Especially if they've had a frozen embryo transfer and there is no benefit
yes.
of corpus
and
luteum
so the
and
Dopplers
protection.
in these groups are very important, and along with that, I will do an additional PLGF. When you're doing the dual marker screening, add on the additional PLGF and the PAPE, so they would tell us the preeclampsia risk. Though we are giving them ecosprin, monitoring for Dopplers and maybe more frequent scans are required. As Vanita said very rightly, looking for the cervix, looking also for the Dopplers. So that would be very important.
Brings us to Dr. Rajkumar Shah. Once upon a time, sir, we used to keep patients on vaginal progesterone till 34 weeks to prevent preterm birth. And that is also endorsed by some of the guidelines. What is your take on that?
So I think after the use of 17-hydroxyprogesterone caprate, which came into disrepute, this has come up as such. And of course, there are studies which have said that using up to 34, 36 weeks probably would prevent preterm labor as such. But in the meantime, we are pushing up incidence of intracholecytic hepatitis.
Yes.
And this is a real fear as such. Besides that, vaginal progesterone is
Though
known.
it is rare, when it happens,
Yeah.
it's difficult to counsel
Manage.
patients.
And it has helped, there's no question about it as such. But very recently there has been a study which says that, okay, below the age, below 35 weeks, vaginal progesterone has not been as much of help, especially if they've had a tightening. So these are certain new issues which are coming up as such, which require to be looked into.
So you need to individualize a treatment. One size never fits all, and make sure that she is always being referred for an institutional delivery, because these patients can present with complications at any point of time during pregnancy.
may
They
require
need to have a
multifactorial.
phone number which they can call up in the middle of the night. All the usual basic stuff which we always talk about. Which brings us very nicely to the question of delivery, and this is going to be the last 5 minutes of this entire panel, where we are going to debate the entire issue of whether every ART pregnancy should always end in a cesarean section. I'm going to start with Dr. Sudha on this side, and we'll take everybody's opinion in turn.
If you want one single word answer, yes.
This is going to be a very polarizing question and debate.
No, I wouldn't agree with it, obviously, because if it's a straightforward ART, relatively young patient, I would say there's no harm, provided there's no other high-risk factors. But if it's a complicated IVF and she's had a history of problems before, yes, then, and I would also discuss with the mother, it would not.
Madam, आपण एक score devise करूया का?
Yeah, we should do it. And, comorbidities, GDM, all those things complicate the picture, and FGR is also very common in this group.
I think besides comorbidity, it is the patient's outlook. I have had quite a few patients, they have undergone many ICSIs.
And Muhurt's
See,
a cesarean
people
file
don't
check.
come to know how you have got pregnant, but people come to know how you have delivered. And they are very, very, very keen that they want a normal delivery. Right, and they are very insistent. So there I tell them, see, if there are no comorbidities, everything, I tell them, yes, I will give you a normal delivery, but my threshold for cesarean section is going to be lower than what I will do for any other person. But there are quite a few of them, they insist. And of course, insisting is different, and how much effort they are putting in, that is different. There are few of them, they really do very good exercises and they can have a normal delivery. So I wouldn't say yes, depending upon the
So again, we have
a
to
patient.
individualize.
I think I am with her. I will.
The men are always very politically correct. That's one. That's the moral of the story. We always concur.
Obviously, we just gave an example. Just recently, 15 days back, we delivered one 41 years old lady, infertile for 7 to 8 years. She was insisting, she had no high risk factors. She did cooperate very well, and she had a normal delivery, 3.8 kg baby.
The only disadvantage of this is what you know. People, you get
God
a
forbid
word
she
that
lands up with
no,
shoulder
no, no, no.
dystocia.
ये doctor vaginal delivery करता है, and then you will get transfers at, meaning they will shift from other doctor to you at 37, 38 क्योंकि हमारे doctor ने हमको section बोला है. So then your stress increases. There is, you know, ये doctor vaginal delivery करता है, इसके लिए they will shift.
No, but one who wants section, you offer them section. One who's
No, that is a disadvantage to us. It's a disadvantage to us that they start shifting
don't
to
think,
us.
I don't think I have repented any time.
Responsibility to you.
One final comment from Dr. Rajkumar Shah.
So I
Or
do
you also
enter-
agree?
I do entirely agree that it should not be always a C-section as such. At least make an attempt to see that you offer normal delivery. If the patient is keen on section, yes, no question about it. Then
I
don't
think you
dissuade
should
her.
take an opinion of the house on this because it is extremely, what are we doing practically is what we need to address. I mean, I leave it to you, you're the boss over here, but I
I'm not
think
the boss, I'm the junior most. I started by saying that.
But just one. I had a 44-year-old who came in saying I've got menopause. I've had 4 attempts at IVF, and Dr. Abina, ab dekh lo, sonography karke dekh lo, and she was actually pregnant, and she was all ready for a normal delivery. And at the end moment, because the platelet counts fell down very significantly, we didn't find the reason. We had to take her up for section, but otherwise she was all ready for a normal. But having said that, you know, the complications that just last I'd like to say, we have to be aggressive in our PPH prophylaxis, whether it's normal or whether it's C-section, because invariably, because of whatever interventions we're doing, the incidence of atonic PPH is on the higher side. So aggressive prophylaxis of PPH is
Maybe not
LMWH
exactly
as
the
well.
adherent placenta, but you can, but some amount of placental dysfunction, and that placenta takes longer to separate, or a part of it can be adherent which is not been picked up by.
Absolutely.
So they do have a,
Incidence of thrombo. Yeah.
Considering that there is a set which is for normal delivery, are we considering induction in these patients or allowing them to wait spontaneously? And because they are ART pregnancies, how long are we ready to wait for them to go into spontaneous labor?
Fantastic
Because
question.
most of
Society
them
for Maternal
land up
Fetal
with
Medicine.
complications at 36, 37
Excellent
also.
question.
The
Nobody.
SMFM guideline recommends delivery at 39 weeks depending on what is the bishop's score.
Right, sir. So are we
But
ready
I
to
wouldn't
induce?
go beyond 39. For me, high-risk pregnancy with an IVF, I wouldn't go beyond 39. Because 40 as it is, I wouldn't want to wait. So I'm 39,
I think
39
probably
plus
the
1 plus
threshold
2.
is slightly lower amongst people who are generally practicing also. I don't know how many will allow the pregnancy to go till
No, but
39.
at Ambani, we've done normal deliveries for IVF patients.
So I think we've come to the end of our panel. We had a fantastic panel talking about aging, both in infertility practice as well as obstetric aging. Covered a lot of ground. We've realized that poor responders are much more common than we realize. The general OBGYN population also needs to be aware that the younger population, typically less than 35 years, can also have reproductive aging. Unfortunately, besides oocyte freezing, there is no foolproof method of ensuring fertility in these women, be they young or old. Adjuvant therapies are something which have come and gone, but the newer class of molecules which we have, like ubiquinol, and the older class, like androgens, have been the mainstay of therapy. Rejuvenation, stem cells, all of these are cutting-edge therapies which in limited trials have shown benefit. We should try and take recourse to them as much as possible. We are also aware that we need a large number of follicles or oocytes in the elderly age group to give us euploid embryos. And if we could ensure that with medication that we get more euploid embryos, obviously the results of our ART treatments would be significantly better. As we said, all of these women are significantly subject to much more complications. assess on a case-by-case basis, look at the gestosis score, screen early for anomalies and for premature opening of the os. Ensure that you do your GDM screening religiously. Many of these women are obese, and as we know, pregnancy itself is a diabetogenic state. As far as labor and delivery is concerned, termination of pregnancy at 39 weeks is what is recommended, but there is no consensus as to what should be the route of delivery, and that is something which we will need to address in the years to come. Maybe we will have a nice multidisciplinary team meeting, and we can devise a new scoring system which will help us assess what should be the mode of delivery in these patients. Thank you very much to all my fantastic panelists. Thank you, ISAR, Dr. Amit Patki sir, and Mumbai Society for this opportunity.
Very well put, concise and really very well put. Good, Pratik. Thank you.
Ma'am. Can we have a picture at the end? Amit sir, could you please come up?
What a crisp gist on this particular panel, which could have been a day-long CMA, I would say, and very nicely summarized by Pratik Tambe sir, and something to ponder over, maybe have a multidisciplinary team approach and make a new score. With this, we move to our next interesting section, which is very, very little understood by us clinicians. And today we have Dr. Deepak Modi, who's going to talk on algorithms for genetic testing in male infertility. May I request upon our chairpersons, Dr. Satish Tibrewala sir and Dr. Kedar Ganla sir, to come onto the dais. Dr. Satish Tibrewala is a senior consultant gynecologist and andrologist, retired from the Bombay Hospital, practicing at Fertility Care Private Limited, ACE Medicine Center Private Limited. Dr. Kedar Ganla sir, consultant fertility, practicing since more than 3 decades, currently the Secretary of Maharashtra State Chapter of ISAR, past Secretary General of ISAR, past Treasurer of MOGS. I welcome you both, sir.
Tell me who sang Yere Yere Pausa this morning? Put up your hands. Okay. And still the rains came down like everybody is saying it or something, you know. So many people are still on their way, and Dr. Khadilkar is on her way too, so I'm just filling in for her. If she comes halfway through, I'll get up. Okay, it's such a great pleasure to introduce you, Deepak. Where are you sitting now?
I'm here.
Oh, there you are. Deepak is a very good friend, and I've been following his work. He's an excellent orator and an excellent researcher as well. He's done his PhD in human genetics. He's elected Fellow of the National Academy of Sciences of India, NASI, in 2020. That's just 4 years ago. At very young age, he's received a lot of honors. He's a recipient of the INSA Young Scientist Award, National Academy of Sciences India Young Scientist Award, Innovative Young Biotechnologist Award. You never seem to age, man. Every time I see you, you're looking younger. ICMR Young Scientist Award and PM Bhargav Oration Award. He's had over 140 publications, and all these are great quality publications, I can assure you. His current research areas are understanding of mechanisms in embryo implantation and placental development, a very, very important field which needs to be developed and studied more. Genetics of sexual development and male infertility, which we will hear in his talk today, which is, I'm really looking forward to that. And COVID-19 and reproduction, how there was what was the effect of COVID-19 on reproduction. So Deepak, I'm sure that everyone is very eager to hear your talk.
Chairpersons.
Yeah, you can.
I hope I'm audible. Yeah. Thank you so much, Chairpersons. And thank you, sir, for inviting me. It's always a pleasure to talk to the clinical audience, which and it's challenging for me because we generally figure out how to make the mouse pregnant. So my friends call me a mouse obstetrician. But how that findings get translated and then we see them changing lives of patients and doctors, it's very satisfying. And it's always great to come to this audience and talk about the work which we have been doing. And the topic for today is about algorithm for genetic evaluations of infertile males. And as said, genetics, I'm sure the word itself is very scary and you just don't want to look at it because it's like, okay, it's just an academic exercise, but I'm going to break some myths today. What my lab is doing has already been told. The work that I'm going to present today is all about the work done by my postdoctoral fellow, Stacy Colasso, and two wonderful graduate students, Sanjukta and Shadan. So basically, let's begin. When we talk about infertility and we talk about its diagnostic workup, we take medical history, physical examination, and at the lab level, we talk about semen analysis and hormone assays. And we try to figure out what are the different reasons why the male is infertile. But let me tell you that irrespective of the cause, most infertile men will require some form of genetic testing. And which ones of those I'll tell you in the next couple of slides. But when we begin with a semen analysis to call a male an infertile male, when we say it's azoospermia, oligozoospermia, or any defective sperm count or sperm number. However, there is a recent term which is getting coined, a normosospermic infertile male, and that's because there's nothing wrong with the female. She's ovulating correctly, everything is going fine, but for some reason the male is unable to get you embryos, or the embryos then, or there is a history of recurrent spontaneous abortions, and epigenetic or genetic causes have been linked there. I'm not going to talk about them. We're going to worry about what's going to matter clinically. So when we talk about quantitative defects like azoospermia or oligozoospermia, they can be either pre-testicular or testicular or post-testicular in nature. Oligozoospermia almost always is going to be post-testicular defect, or it could be pre-testicular at the level of the hormones. And asthenozoospermia or teratozoospermia is where the sperm making is going faulty in the testis. And all of these conditions have a genetic etiology. So for example, we are not again going to talk about normozoospermia, we're going to talk about azo and oligozoospermia. In the non-obstructive azoospermia, karyotyping defects will be observed in 10 to 15% of couples, and Y chromosome microdeletions in another 10 to 15%. So often I hear from my clinical colleagues and friends that, oh, I do Y karyotyping and I do Y chromosome microdeletions, but we don't get them. You're not going to get in 90% of the patients. You're going to get only in 10% of azoospermic patients, or about 20% of azoospermic patients. So please remember that azoospermia, oligozoospermia is multifactorial. There are many, many causes of this. In about 10 to 20%, there's going to be a genetic involvement. So it's important to diagnose that. I'll tell you why in some time. And similarly for oligozoospermia, karyotyping defects are at a slightly lower frequency, and Y chromosome microdeletions also on 5 to 10%. When it comes to asthenozoospermia or teratozoospermia, where the sperm structures or motility are abnormal, do not worry about getting a karyotype done. It's not going to yield anything because these are not because of a karyotype defect. There are defects at single gene levels, or there are defects in the tail proteins, and therefore doing a karyotyping or a Y chromosome microdeletion is not going to help unless the patient is having severe OATs. In severe OATs, we do find Y chromosome microdeletions. In a very small fraction, you will find karyotyping defects, but by and large, they are normal at these test levels. So choose your test wisely depending on the semen parameters. It's just because it is abnormal male, or just because it's labeled as male infertility, we do not just rush up to a genetic testing. So now the next question is, okay, fine, we did this exercise, but what is it going to do? How is it going to help me or my patient? Because by the end of the day, the patient has come to me for biological parenthood. They want biological parenthood, and therefore they have walked up to the clinic. They've already explored other options. And how are these genetic testing going to help me? Is it going to change the clinical management? Is just merely an academic exercise? This has been a burning question for a very long time, and let me tell you, genetic testings are not academic exercises. They do have a very distinct path which you can follow. So first, to begin with, when we talk about, again, male infertility, especially in oligospermia, we talk of a lot of lifestyle changes. We say that, okay, you avoid alcohol, have a good healthy life, go for yoga, go for exercise, avoid taking hot baths. We talk about eating healthy, we give vitamin supplements, antioxidants, hormonal supplements, so on and so forth. Typically, these all run for 1 to 4 months. I'm told it's even longer, but often you will see results are inconsistent. Some men improve, some just don't seem to improve, some just worsen over time. And trust me, none of these have been proven by a randomized controlled trial. They have been all done empirically. And the effects are seen in a small subset of patients, and that too, the effects are very variable. But if your patient has a genetic defect, remember, then the entire machine is at fault. So whatever that forms of treatments or therapies that you would do, nothing is going to change. So in such men, it's best not to do any forms of hormonal therapies, any forms of antioxidant treatments, give them hope for 3 to 5 months, because the machinery by itself, which is going to do spermatogenesis or make sperm, is faulty. There's a genetic cause. And in such men, there will be no improvement by any medical treatment, so it's best avoided. They can be directly posted for assisted reproduction if that's what they have come for. The next point is, now let's look at an algorithmic approach, because that's the primary topic of the interest, that when you have abnormal semen parameters, you begin by classifying your azoospermia as obstructive or non-obstructive. To choose your genetic test, you need to classify this appropriately, and I'll tell you why. Oligospermia, astheno, or it could be both oats together. When it's obstructive azoospermia, the only single test you need to worry about is CFTR gene analysis. If it's non-obstructive azoospermia, oligospermia, or oligoastheno, get your karyotyping done and Y chromosome microdeletion done. There's a fad of doing this exome analysis. A lot of genetic companies will come to tell you we can do exomes. Do not get carried away by them. They're very expensive tests, and as of today, I would tell them they're in research phase and not clinically relevant as of today. We do not know what to do with those results. And when it comes to asthenospermia, please get analysis of something called as multiple anomalies of sperm flagella, not classified by WHO, but it's a condition where there are sperm tail abnormalities, and in this condition, only exome analysis is recommended. So when it comes to obstructive azoospermia, again, it's not directly CFTR testing. A renal ultrasound is absolutely necessary if there is a renal involvement, that is normal kidneys or abnormal kidneys. Only if they're normal kidneys, that CFTR gene mutation testing is going to be informative. 90% of them will have this. But if there is no renal involvement, do not bother about getting them. When it comes to congenital unilateral absence of vas deferens with a conlateral obstruction or a bilateral obstruction, again CFTR testing is essential. But if it's isolated unilateral absence of vas deferens or a CAVBD with renal involvement, do not ask for CFTR gene testing. It's not going to yield you results because the pathology is now something else at the genetic level. So choose your test wisely. And I typically recommend that a renal ultrasound is the determinant of which test to choose. And there's a paper which is published by my colleague Dr. Rahul, where he also says that again, when you ask for a CFTR gene testing, most genetic labs will give you the delta 508 mutation. Does not work in Indian population. Only 8% of men will have a delta 508 mutations. Rest of it will have mutations elsewhere. So when you ask for the patient, ask for the whole gene sequencing. Again, not exomes, just a CFTR gene, which is multiple exons there. All of them have to be tested so that you will find mutations. And a policy brief has been published by ICMR. It is there on our websites. Anybody who wishes can follow it. I can send you a soft copy which can be circulated. So now that's more about the obstructive azoospermia. So this is in summary about it. Now you will tell that, okay, fine. I did the CFTR gene mutation testing. So what? Please remember, based on Rahul's work, which is the largest data set from the country, 16% of the partners, the couple's partner, the female partner, also had a CFTR gene mutation. Now when you do a ICSI with this, you are going to give them a baby with cystic fibrosis. You do not want to do that. So please remember, if there's a CFTR positivity, test the spouse. The spouse is, if she's a carrier, immediately opt for PGT-M. That's the way to go. Because you would then select the embryos which are cystic fibrosis negative. So you're not just giving the couple a baby, but now giving the couple a healthy baby. Do not land up giving them a baby which is cystic fibrosis. That's not the way we should do it. We are now in time of personalized medicine. Let's customize it this way. So this, to cut the long story short, look at both the couples for CFTR gene mutations, and if both the couples are positive, opt for PGT-M, or tell them that if you do not want to do it, opt for other means of reproduction. Non-obstructive azoospermia, rule out the iatrogenic causes. Karyotyping and Y chromosome microdeletions are your friends there. And karyotyping defects when it's 46XX, extremely rare. In my entire career of genetics, I've only seen 2 men with 46XX karyotype, but if you land up getting them, these men will have no spermatogenesis in the testis, not even focal. It will be SCO or a completely burnt out testis. Do not offer them any form of TSA-ICSI. You'll never get sperm in them. When it comes to 47, the Klinefelter phenotypes, they have a variable presentation, they have focal spermatogenesis, you can get sperm from the testis, and they're candidates for TSA-ICSI. And polymorphic variants as well, which many of the geneticists will tell you, don't worry about them, but that's not true. They are variants of unknown significance, but in infertility, they have been defined to be a cause. They will have focal spermatogenesis, you can have sperm from them. But when there is a translocation detected on the Y chromosome microdeletions, or when there is a Klinefelter phenotype, immediately offer PGT-SR or PGT-A, because when there is a Klinefelter phenotype, the sperm will be disomic for many, many chromosomes because the meiotic disjunctions don't occur appropriately, and a good proportion of resulting embryos are aneuploid. So PGT-A is your partner there. And if it's a translocation carrier, immediately offer PGT-SR. It's a simple math that when there is a one translocated chromosome, 50% of the resulting embryos will also have the translocated chromosome as well as the extra chromosome from the translocation partner, resulting in a genetically disbalanced embryo, which will either not implant or implant and abort. You would not want to get into that. About 25% of embryos will be normal, 25% of them will be carrier. And if you apply PGT-SR in your patients with translocation carrier, a very beautiful study has been done by Dr. Gunishila from Bangalore, published last year. She's shown that after applying PGT-SR, the clinical pregnancy rates shoot up to almost 72%, and the live birth rates per ET are 66%, which is way higher than what you would otherwise anticipate not applying these technologies. So PGT-SR, so in couples with Y chromosome microdeletion, sorry, the karyotyping abnormalities, please offer them PGT-SR or PGT-A depending on what they need. The next genetic abnormalities are Y chromosome microdeletions, which my lab has been researching on for the last 15 years. And they are not deletions which you detect on a standard karyotype. Karyotype will be normal, but these are really submicroscopic deletions which need PCR to be tested. And we had shown that in about 3,000 men from India, the prevalence of Y chromosome microdeletion is about 5.8%. It's slightly higher in azoospermia, slightly lower in oligospermia, but by and large not significantly different. Something that interesting came out from our study was that in the European population, they always said idiopathic azoospermia or oligospermia do a Y chromosome microdeletion testing. But in our population, we found that even if they are patients with unilateral or bilateral cryptorchidism, chromosomal abnormalities or varicoceles, they were carriers of Y chromosome microdeletions. So what's working for the European population does not work for the Indian population, and therefore most men with azoospermia or oligospermia should be tested for Y chromosome microdeletion. Now the problem is that when we were doing these studies, and often today my colleagues tell me that, oh, India mein to bahut kam milta hai, and honestly we only found the prevalence to be 5%, unlike in the European population which was 12 to 15%. And you are wondering why, and typically wo genetics wala dimag, we thought, oh, there must be a population variation, some other genes must be involved, all the da. We did for almost 10 years, found nothing, only to realize that when our patients were diagnosed using the European markers which were recommended, the 6 European markers, the frequency was only 5.5%. And when we added other markers to the panel, we realized we were missing out 48% of our cases. So you were under-diagnosing 48% of our cases because we use a wrong set of markers. So we said this is not done. In India, we need India-specific markers. So Stacey took up this challenge and she did a lot of work over a period of time. And finally she said that 6 markers don't work for us. We need a 14 marker panel. She's converted this 14 marker panel now into a diagnostic assay. And this assay is technology is being transferred. Soon it will be available in your diagnostic labs. This assay is straightforward and simple. Anybody who has a genetic lab has access to it, can utilize it, where you just count the number of bands in a lane and you will know whether there is normal or abnormal. So for example, here, this patient, normally you should have 2 bands in one of the lanes, but this patient is only 1 band. It's a straightforward interpretation of a GR deletion. And similarly, there are interpretations of AZFB plus C deletion. So depending on numbers of bands, presence and absence of bands, a genetic lab, even a 12th pass bacha who comes to my lab now does this test and interprets it very, very quickly. So it's no more now a complex test. It's going to be easily available, easily accessible test which you can use. And when we used our test in our cohort of patients, we found that all those which were missing were diagnosed by this. And when we use the appropriate test, you will get around 10% of the men who will have Y chromosome microdeletions. So now again the question remains the same, that fine, these men will have some spermatogenesis occurring in their testes. We could offer them TISA, ICSI and give them babies. Definitely you can make embryos out of those sperm, you can make multiple babies, but please remember that the father is always going to give the Y chromosome, and these Y chromosome when deleted, all the sons born out of that ICSI experiment will have the Y chromosome microdeletion, and therefore with every additional son given to such couples, you are going to double the number of infertile men in the country. Now fine, when you tell this to your couples, the couples will say, sir, aap mujhe bachcha de rahe ho, mere ladke ko bhi bachcha de doge, technology will evolve. So obviously as healthcare providers, we cannot stop them from having babies, but it's important to inform them, and many a times the couples change their decision. They say, no, if I'm suffering, I don't want my kids to suffer, fair enough. But it is important for you to give them that information that the children born, at least the males born out of this, will be infertile. Nevertheless, finally, why should this matter? Because हम बच्चा दे पाते हैं उसको, तो उसके बच्चे को भी बच्चा दे ही देंगे. Big deal about it. But there is something more interesting in the bag. This study we published in Fertility Sterility earlier this year, where we reported that it's not just about detecting the Y chromosome microdeletion. But if you compare a group of azoospermic men without Y chromosome microdeletions and those with a AZFC deletion, the chance of extracting sperm from the testis almost doubles. It's a statistically significant because AZFC deletions, most of the other genes are well preserved, which will allow some form of spermatogenesis. So you can use this test and counsel your patient that, okay, if you want to undergo TISA-ICSI, you are having a Y chromosome microdeletion, AZFC, the likelihood of getting a sperm is much higher than your non-deleted counterparts. It sounds counterintuitive, but it is true because in the other set of men, we don't even know what are the causes of azoospermia there. Nevertheless, things are not that hunky-dory, because what we have also shown is that these Y chromosome genes are expressed in early embryos. Most of these XY embryos will express these genes, and when they are deleted, these embryos don't grow very healthy. And that's what Stacy showed, and we showed in our paper that the fertilization rates, however, although you have a good chance of getting an embryo, the fertilization rates are significantly lower, and a proportion of good quality grade A embryos are significantly lower versus yet to come. The live birth rates, the clinical pregnancy rates and live birth rates are half. So when you have such couples, inform them that will give you, you may get a sperm. Your chance of getting a sperm is good, but you will not get success in the first cycle. Your chance of success is fairly low. You will need to repeat your cycles, and you will need to do embryo pooling, and yet with the embryo pooling, the chance of pregnancies are low. Now the problem is, as clinicians, these numbers in a conference, by the time you leave out of this room, you'll not even remember, and these odds ratio mean nothing when a patient is sitting in front of you. I completely understand that, and we will be boggling about how to get this to you in a more effective manner, but we have got it. We used AI here. We took all the data of the men with Y chromosome microdeletions, their hormonal and clinical parameters, their IVF outcome data, and Abhishek and Priyanka at Amity University developed this software, which we call it as a Fertility Y predictor. What you get to do here is that depending on what the deletion of your patient is carrying, is it of A, B, C, is it a B plus C, A plus B, whatever, it will give you an outcome. It will tell you that, okay, what is going to be the success rate. So for example, AZF A and B deletions, classical textbook told us that you will never get sperm in them, you'll never get them pregnant. The answer is no. You can give them biological parenthood. There's a good chance. The chance is only 20% to get sperm. The chance of getting clinical pregnancy and live birth is 13%, but there's a chance of biological parenthood. Do not deprive them. Have this information handy for yourself, for your patients. And similarly for GRGR or AZFA, the chance of getting sperm is fairly high, but if you land up getting the embryos, the chance of clinical pregnancy rates are no different from AZFA or B deletions. So this kind of analysis coupled with Y chromosome microdeletion testing and such analysis will help you to take a very effective clinical decision making, and I hope we should be doing justice to this men, which we have ignored for the longest time. And again, there is a policy brief on our website. You can have a look at it. So just to summarize the algorithm, non-obstructive azoospermia, karyotyping and Y chromosome microdeletions are your friends. Karyotyping abnormal, straight go counsel them, and they are candidates for PGT-A, PGT-SR. But if there's a deletion found, they're not candidates for PGT-A and PGT-SR. They'll have a good chance of vertical transmission, poor ART outcomes, and some of these men, now there are reports coming that they have cardiac abnormalities at later on in life, or even neuropsychiatric issues. So these form a part of your counseling. If you are aware of it and you can counsel appropriately, great. Otherwise, catch hold of a counselor, and the counselor will do the needful for you. However, if you have not found anything, many people do recommend exome sequencing, but I must tell you that this is in research phase, not to be used routinely unless your patient is insisting. I mean, these days patients do Google and insist a lot of things. There is no need to worry, but if you have done an exome, please do it with the partner also, because then these patients opt for PGT-M, because if there is a mutation found and the partner is also a carrier, they need to go for a PGT-M. So do not deprive them of that. Finally, I told you about multiple abnormalities of sperm flagella. Not a diagnostic criteria by WHO manual, but they will, your lab can tell you that there are sperm tail abnormalities, which are curl tail, short tail, abnormally looking tail, split tail. All these have mutations in genes required for tail formation. In this case, definitely exome analysis is recommended. In about 30% of cases, you will find mutations in tail proteins, and these patients are now classified as patients with ciliopathies, because it's not just the sperm tail which are abnormal, but all these cilias which are throughout the body, in the lung and everywhere, there'll be abnormalities. And then if there is again a female partner who is a carrier of the mutation, PGT-M would be required there. So whenever you do exome analysis, if there is a strong candidate gene found, And if it is known to be linked with a more stronger anomaly, ask for the female scan. And do not do these without consulting a genetic counselor, because these calculations are fairly complex. Unlike the Y chromosome microdeletion, which is pretty straightforward, always have a genetic counselor at your disposal when you're offering exome sequencing. So just to summarize the whole thing, I call this as evolving paradigm of androgenetics. We need to start worrying about androgenetics, where Y chromosome microdeletions and karyotyping together will give you the cause of infertility in about 30% of your cases. Those with karyotypic abnormalities are candidates for PGT-SR. Please offer them so that the chance of pregnancies go up. Y chromosome microdeletions must be done using tests which are validated for Indian population. Ask your lab, how many have you done? How many markers are you using? If you're using the 6 valid markers, those are European markers, does not work for us. They have a low but a reasonable chance of biological parenthood. They are going to transmit the defect to their sons, but using this information, you can predict the success rate of IVF. CFTR gene mutation only to patients with CABVD without renal abnormalities. Offer PGTM if the partner is found with CFTR gene mutation, because that risks cystic fibrosis. Male infertility definitely has a strong genetic involvement. You may subject them to NGS or exome analysis, but not without consultation of a genetic counselor. Last but not the least, these patients will never benefit from any form of therapies. Do not try to attempt them, waste your time, their time, give them hopes. It's best to give them a closure that here is a genetic problem. Your chance of getting cured by any other means is absolutely zero. Either you go ahead with these or opt for donor semen or adoption. Thank you so much, and if there's time, I'll be happy to take questions. And I thank all of you as taxpayers, because it's your money which has finally come to me to do all this research. So all of you are equal party to my research, and thank you so much for it.
Any questions from the audience?
Everybody's overawed with the information, I think. A lot of information and very important information. I wanted to ask you that you are doing microdeletions at IRR, NIRRH. Is it available for doctors who are present here to refer patients to you at IRR?
Yes, definitely. So we are doing this test in our lab. It's free of cost, no charges, because we found an institute. You can definitely send your patients.
But do they get the report back? Because in the past, the problem was that the report is not given in writing. It's only verbally communicated.
We do give the report back in writing, but it's not like a typical diagnostic lab where you will get it in 2 days, 3 days, because our technicians and students are busy. But within a week's or 15 days time, we definitely.
So the waiting period is
about
a week or 10 days.
Yeah, but
there is no charge.
There's no charge.
No charge. So we can all become partners in this research that they are doing. I remember initially he used to say that internationally they are saying a higher percentage of microdeletions, but we are not finding it that high. And then later on when I met you, you said we've started using more probes, and now we are finding that the incidence is approaching the international levels. Now I want to ask you one more thing, is that if we do find that there's a microdeletion and we refer the patient for testicular sperm extraction and ICSI, can we do sexing of the embryo so that only the female would be transferred? Does the government allow that in this condition?
As of today, no, because it's not a lethal condition. It's not life-threatening. So, no.
So, in this condition, you'll not be allowed to sex the embryos. That is required for us to understand, because in counseling, the patients may ask us this, that then why don't you transfer only the female embryo? So, it's not allowed.
Very clinically relevant question. Any count less than 5 million and you do serum FSH, which comes like even in 1 million, FSH comes normal.
Yes.
Okay. And we are very hopeful now that we give medicines and this FSH would rise. But after 3 months, nothing happens. So how does genetic explain this particular thing? Whereas the FSH should have been raised by 1 million count. It should have been very high, but it doesn't seems to be in certain patients, doesn't come that way. And that's the reason we are hopeful and we keep treating them.
Yes.
Do you
So-
have an answer for this?
Yeah, so that's one reason. So I'll give you the technical answer a little later, but that's one reason we do not recommend using hormones as a parameter, as a surrogate parameter to predict if there's a Y chromosome microdeletion. There is no relationship. Earlier people used to say high FSH likely of Y chromosome microdeletion. We have found there is no relationship. Even normal FSH there is. Now the problem being that FSH levels only are indicative of Sertoli cell functions and leading cell functions. Whether they translate to the germ cell spermatogenesis, the system is not sensing that the sperm is not being produced. And therefore it's not modulating its FSH levels. It's as straightforward as that. Now why it is not sensing is a matter of research, we don't know.
Does the volume of the testes indicate success at finding sperms on sperm extraction?
As of now,
Testicular
no.
extraction?
As of now, no. No.
Testicular volume, even in smaller volumes, testicular volume,
We
you
took
can still
almost
find.
all of the ever data that we had, put it to the AI. AI said nothing seems to be correlating.
So even
Nothing.
3 ml, 4 ml, 5 ml testes, you can still find sperms in them?
Yes.
And flaccidity of the testicular tissue, will that help to understand? If it is flabby, then less chances than if it is firm?
I don't think. Because see, the point is there is focal spermatogenesis occurring somewhere. If the couple needs biological parenthood, you better do it. Because these are just predictive numbers which will tell you probability. This doesn't help the patient. Sure. Thank you.
Thank you, Deepak.
It's a wonderful session. Thanks so much, Deepak, for all the information.
I think only Dr. Deepak Modi could have done such a justice to genetics, because as clinicians, the moment we hear the word genetics, everything goes over the head. But it was a very, very nicely summarized parameters, what to do and when to do. With this, all these years we have been hearing about motherhood, maternal aging, and effects on fertility and pregnancy outcome. But since we are moving into an era where we are educating our couples that it is the journey of parenthood, there is an interesting topic. What is the impact of paternal aging on the outcomes of infertility? And before we have the oration of Dr. Amit Patki sir, which is also going to be simultaneously relayed at 10 cities, we'll have a nice 12-minute presentation into the insights why we are going to have a talk on this particular topic.
TikTok Y, cracking the code of men's biological timekeeping. Ancient Egyptians used water clocks to measure the time. In 46 BC, Julius Caesar introduced the Julian calendar. And a few hundred years later, in 1582, Pope Gregory XIII replaced the Julian calendar with Gregorian calendar. And this is what we follow till date. We had mechanical clocks started ticking away in the 14th century in Europe, and pocket watches became trendy in the 17th century. Timex was founded in 1854 and the legendary Rolex was introduced in 1905. And today, we use the smartphone to measure time. But billions of years before all these timers, there were the living cells themselves, impeccable timekeepers with astonishing precision and accuracy. Our 37 trillion cells follow an invisible clock that kept the tempo on growth, and it set a biological timekeeping to its growth. Hello, I'm Dr. Amit Patki, President at ISAR for 24-26. I'm going to talk about the biological timekeeping, but in men. Yes, you heard it right. Does time and clock matter to men and sperms? Time is set for the sperms to fertilize, and if the time is crossed, it weakens the sperm. Paternal DNA repair happens in a stipulated time frame, failing which leads to a stressful replication error.
Embryos divide at an awesome speed and time. Time is set for an embryo to implant. If not, it leads to apoptosis and fragmentation. Likewise, there is an invisible timeline kept as biological clock in men to beget children, and failing this leads to a radical ruin in the offspring health via de novo mutation. This is a 2000-year-old philosophical problem discussed by great philosophers like Aristotle and Plato. Men can produce children even at 80 years, but the truth is stranger than assumptions. JAMA Psychiatry 2014 looked at researchers who analyzed more than 26 lakhs children born to young dads between 20 to 24 versus dads 45 years and older. And they followed them for 3 decades. The outcome? 24 times more bipolar disorder, 13 times more ADHD, 3.5 times more incidence of autism spectrum disorders, higher suicide tendencies, academic morbidities, and increased addiction to drugs. My dear friends, stay tuned for the oration Tick Tock While, cracking the code of men's biological timekeeping. Esse homo, it's time to look at men.
With this, I think now all of us are going to be glued to welcome Dr. Amit Patki sir to listen into a very interesting topic of the impact of paternal aging. For this, I'm going to invite our chairpersons for this session, Dr. Satish Tibrewala and Dr. Rajkumar Shah. We had the introduction, and very, very senior fertility consultants and have their expertise for more than now 4 decades. We welcome Sadhna Desai ma'am for gracing this occasion and giving her blessings. Ma'am, can you give, okay.
The 2 stalwarts sitting next to each other, Amit and Dr. Sadhna Desai, my teacher, my examiner, my teacher. Very interesting now, talk on aging of the male and effect on reproduction. And we are looking forward to the talk from Amit Patki, who is, of course, we all know he has his IVF center, of which he is the medical director. He is consultant at Khar Hinduja and Surya Hospitals. He is president of ISAR now for 2 years, so we have many more programs, and he's keeping us all on our toes with all the programs of ISAR coming up, one every month, it looks like. He is also country representative for Aspire, governing council member of ICOG 12 to 21, and vice chair MSR 23-25. MSR is the Maharashtra chapter of ISAR. He is chair of the West Zone RCOG 15 to 20. He was, and he is president of MOX. He has been president of MOX for 1 year, 14 to 15. He has 35 publications in national and international journals. 50 book chapters, wow, and editor of 3 books, 2 international patents in infertility and stem cell research, and he has also been a TEDx speaker. Those of you who listen to TEDx, they are all quality speakers, so that speaks for the quality of your work and your speech and oration. So look forward to this now, Amit.
Thank you very
The stage
much.
is all yours.
Thank you very much, and thank you, chairpersons, for your kind introduction. I dedicate this talk to Dr. Sadhna Desai, one of our most senior fertility specialists, but extremely young at heart, always willing to take part in any of our educational research activities. and very few of you would know a very great philanthropist. So thank you, ma'am, for being here today on this very special day of our World IVF Day. We did listen to a panel on maternal aging, and we had a wonderful talk with Dr. Modi giving us the algorithm of how to look after female infertility. But I thought we would complete this by having some thoughts on paternal aging and ART outcomes. So we always, when we talk of aging, we always look at aging as a woman's only problem. And this is also expressed by the lay media, by the lay people and media, because you have 3 Time magazine covers which talk about aging as showing you women's pictures. The science of living longer, forever young, and how to live to be 100 years. We also have medical journals which talk on why we age, and the cure for aging is always directed towards the woman. But I think it is time that we now talk about men and aging, because just like women, men carry a biological clock, especially when it comes to reproduction and the ability to produce optimal embryos, especially after ART procedures. So I would love to see a Time magazine which talks about menopause, which talks about the male biological clock, or having a male child which says that how to live to be 142 years. James Crow, who has been a professor emeritus at the Wisconsin University, said in one of his editorials, the greatest mutational health hazard in the human population at present is fertile old men. And we have a large number of celebrities who have been acclaimed because they had children beyond 60s, 70s, and some of them even in their early 80s. And this, he says, is the genetic health of our human species is now facing a serious threat. They are fertile, but obviously they pass on some de novo mutations to the children. And that is what we are looking at, how paternal aging affects not only ART outcome, but affects the newborns. As far as fertility in men and women was concerned, this is nothing new. It was there even 2000 years back. And there's a very nice painting which depicts the dialogue between Plato and his student Aristotle more than 2000 years ago. And Aristotle asked Plato, what age should the parents be in the prime of life? And he says it's a period of 20 years in a woman's life and 30 in a man. He says a woman, when she's 20 years of age, may begin to bear children to the state and continue to bear them until 40. And a man, when he's 5 and 20, which is 25, and when he's past the point at which the pulse of his life beats quickest, which means he has matured over time, and he can continue to beget children till he's 55. I think our ART laws have taken up exactly from this, but this was known even 2000 years back. And he says this is the age that they are physical prime and also intellectual vigor. And in case they have children either earlier or later than this, the child is an offspring of darkness and strange lust. When we talk of male reproductive aging, we said it's a radical road to ruin, only because we know that in an advanced male age, there is diminished antioxidant protection, comorbidities set up, unhealthy lifestyles, and dysregulated cell metabolism will all imbalance the redox potential. So there is increased ROS generation. In addition to this, with age, there is reduced testosterone production, and hence we find that the years to conceive increase even when the paternal age goes more than 45. So the advanced paternal age will give us histological alterations of testicular vascularization decrease, a decrease in the thickness of the basal membrane of seminiferous tubules, so spermatogenesis is affected, decrease in the Sertoli, Leydig cells and the germ cells. As far as hormonal changes, there is decrease in the free testosterone and total testosterone. There is increase in SHBG, increase in FSH, increase in LH levels. And then you look at the basic semen parameters, you find that there is a decrease in the semen volume, decrease in sperm counts, motility, and morphology. In addition, you have increase in the sperm DNA fragmentation, which leads to increased oxidative stress. Add to this, the sperm counts in general are decreasing globally at an accelerated pace. And just to give you the extent of the problem, prior to 1972, the average sperm count was nearing 100 million per ml. When you look at 2018, the average sperm count is barely 49 million. So the rate of drop of sperm count prior to 1972 was minus 1.16%. But after 2000, the drop has been more steep. The rate of decline is doubled at minus 2.64%. A very nice study published in 2017 have shown that in the US, the age of fathers is rising, and this is over a large number of births from 72 to 2015. And they have said that the mean age of fathers has increased from 27.4 years to 30.9 years over the last 50 years. So when you look at the semen reports with the father's age, you find that particularly after the age of 45, there is decrease in the concentration, decrease in the semen volume, motility, and the total motile sperms. So men less than 45 had a significantly greater semen volume than men over 45 years, and this linear regression analysis have shown a significant decline in the semen volume. So you have a decrease in the total motile sperms, and obviously all this is going to affect the fertility potential of these men. But remember, they still remain fertile. So when you look at the relationship between male age and selected genomic defects, you find that there is definitely an increase in the sperm DNA fragmentation with male age. You also find that XY21 aneuploidy sperms increase with age, and there are de novo mutations like achondroplasia mutations have increased. So the probabilities of producing an abnormal sample increases with increased age, and this probability for abnormal motility, for DNA fragmentation, count, and aneuploidy sperms increases with advanced paternal age. Recent papers of 2020 have shown a systematic review and meta-analysis that over the last 2 decades, childbearing at latter ages, be it in women or in men, has increased. And we know that independent of the maternal age, increased paternal age is leading to increased spontaneous miscarriages. We know although the paternal effect is less pronounced than maternal age, but it has got implications for your preconception counseling, especially when you have an older aged men, particularly over the age of 45 and definitely over the age of 50. So a systematic review has shown that when the paternal age is over 40 years, it is associated with an increased spontaneous miscarriages, even when it is adjusted for maternal age,
especially in the first trimester up to 13 weeks of pregnancy. So fathers between 40 to 44 years were 23% more likely to contribute to the incidence of spontaneous miscarriages before 20 weeks of gestation than younger fathers. And when the paternal age was over 45, the risk of pregnancy loss before 20 weeks was increased by 43%, and in the early pregnancies up to 13 weeks, it was increased by 74%. So a large number of your spontaneous miscarriages are related to paternal age. So pregnancy losses, so there is increase in the spontaneous miscarriages, there is decreased blastulation rate, so there are lower implantation rates, and naturally you will have, because of all three, a decreased live birth rates in advanced paternal age. So when you look at months to conceive, this graph very well shows you that after the age of 40, the months to conceive triple than in a younger father at 20 or even at 30 years of age. Impact of paternal age on infertility, you find that it is relatively same till the age of 40, and then once the paternal age crosses 40, and definitely after the age of 45, you find that there is a 2.5-fold increase in the incidence of miscarriages. Now all this is worrying because we know that in advanced paternal age, you have a slightly lower chance of getting pregnant, increased risk of miscarriage. But as I said, they are still fertile. The good news is that paternal age is not related to aneuploidies in the babies. So two large studies, 2017 in ASRM and 2018 in JRRG, have shown that advanced paternal age does not affect the embryo aneuploidy, and they studied this by fertilizing them with young egg donors. So there wasn't any significant trend in the prevalence of aneuploidy across various paternal ages. Now this is a study from one single center of 3,118 embryos which were derived from young egg donors but fertilized in three groups: fathers less than 39, fathers from 40 to 49, and the third column is fathers over the age of 50. And as you can see, the euploidy rate is almost the same, the aneuploidy rate is again almost the same, and even the mosaicism in these embryos is almost the same. So this large study from a single center has a strength because all genetic analysis, embryo cultures, ovarian stimulations were done in a single center, thus eliminating various other variations that can happen because of protocol, embryo handling, or the quality of the lab. So the good news was that advanced paternal age did not increase aneuploidies in these babies. Then why am I standing here and talking to you about advanced paternal age? The reason is because the probability of obtaining an optimal embryo decreases with paternal age. It affects embryogenesis, and more important, it causes de novo mutations. These are papers of 2024 which have clearly shown that there is increased risk of miscarriages, but doesn't imply that there are any aneuploidies in these pregnancies. So a father of 25-year-old has 53% chance of having a good 4-cell embryo and a 38% chance of having a good 8-cell embryo, as compared to a father of 45 years old, where the day 2 embryo chance is only 35% and a mere 20% chance of having a good 8-cell embryo. So the number of good blastocysts that you would obtain from these advanced paternal age would be low, thereby giving you low implantation rates. This was a
study which was published from UK, from the Guy's Hospital, which a single center study which said that paternal age over 50 significantly affects the chance of achieving a live birth following ART. They said that it doesn't independently affect the risk of miscarriage, but the importance is that we should be counseling such couples when there is advanced paternal age, and also as we tell women not to delay motherhood, we should also be talking to fathers, asking them not to delay fatherhood. So the effects are that we know that it affects outcome. We know that there is not clearly defined what are the probabilities, but we know that it can cause some amount of de novo mutations. Now, what are these de novo mutations that can happen? 1 minute. Video can chalate. So when we talk of increased DFI or increased ROS, what exactly are we implementing? This is a video which shows you how DNA fragmentation affects compaction of the chromatin in the DNAs. So when there is DNA damage that occurs, it is associated with a lack of chromatin compaction, and because of which there is consequent retention of histones. Now this means that it is in two stages. The first stage is that the remodeling of the sperm chromatin during spermatogenesis is impaired, leading to poorly compacted sperm nuclei. So the sperm nuclei are not well compacted because of an abnormal ratio of histone to protamine ratio. In the second stage, this video shows that how this vulnerable, less compacted DNA is subjected to attack not by nucleases but by the ROS from the mitochondria. So exactly what happens is that when there are multiple breaks in the DNA, it will code for some abnormal sequence, thereby giving you rise to new or de novo mutations that happen. So fathers transmit DNA modifications to the offspring. This insult occurs during the sperm development in the testes or during maturation in the epididymis. And because it is not well compacted, multiple damages are happening. Now how was this picked up? Way back in 1800s, William Weinberg said that in large number of children, the last born child was born with some de novo mutations. So in the high order children, so if there are 5, 8, 9 children, the last child would have some de novo mutations. And initially it was thought to be something to do with the maternal age. It was only when Penrose in 1955 said that it is the paternal age and not the maternal age which is predictive of de novo mutations. And how did he justify? He said the spermatogonial cells replicate every 16 days. So approximately 200 divisions by age 20 and more than 660 divisions by the age of 40. In contrast, and every time there is a division, there are going to be these breaks, and every time these breaks are then multiplied. By contrast, the egg or the oocytes undergo only 24 cell divisions, of which all but the last one occurs before a woman's birth. So the de novo mutations are mainly because of the father's side, and paternal aging or increased DFI is one of the reasons, and that is why James Crow said that the greatest mutational health hazard is the fertile old men, because they are able to give pregnancies, but these pregnancies do not have any aneuploidies, but will come up with some de novo mutations. Now I don't know whether this graph can be seen well, but these are the various different problems that can occur with advanced paternal age, starting from achondroplasias, Marfan syndromes, cleft palate, patent ductus arteriosus, preterm births, preeclampsias, childhood cancers, very commonly seen associated with advanced paternal age, like retinoblastomas or ALL, autism spectrum disorders, adult onset schizophrenias, ADHD, and bipolar disorders. So when you look at advanced paternal age and autism, this graph very clearly shows you that once the paternal age goes more than 40, the odds ratio are significantly increased. And the same thing is advanced paternal age and schizophrenia. Once the age of the father is more than 45 and definitely over 50, you will find that the incidence of births almost doubles as far as adult onset schizophrenia. So, ladies and gentlemen, the man's biological clock is also ticking. But let me go and shift into another gear, and this is reproduction as a window for health in men. And what was the eye-opener for us? We analyzed 100 couples who came to us with a previous IVF failure, where male factor was not one of the reasons for the IVF. And when we did their DFI, their sperm DNA fragmentation, we found that a large number of them, almost 50% of them, had increased DFI. When we looked at them in details, we found that 24 of them were over the age of 40, 21 of them were pre-diabetic or diabetic, 12 were diagnosed with hypertension, thyroid issues, obesity with a BMI of more than 30, smoking of more than 25 cigarettes a day, alcohol of more than 6 units a week, varicocele on examination in 15 of them, deranged lipids, and we had 2 of them with abnormal karyotypes, and 2 of them on chronic medications and supplements, particularly creatinine powders that they take for bulking up or beefing up. Now these men were never picked up for male factor because the semen report was fortunately normal. So once the semen report is normal, the focus moves away from the man, and we rarely do any investigations on these men. So the take-home message is just don't go on the semen analysis. If you see somebody who's 115, 120 kgs in front of you, who is a chronic alcoholic, smoker, diabetic, I think we need to look at them more in details, because these are the ones who will give you decreased fertilization, decreased blastocysts, decreased implantation, increased miscarriages, and then later on many more problems. So we know that man's health is also related to his fertility, and we found that when there is male infertility, the incidence of all cancers is moderately increased, particularly testicular cancers is quite high. And my second message is that if you all do TISA or a testicular biopsy, please send a small sample for histopathology to pick up the 2% incidence of carcinoma in situ in these men with severe OATs. Prostate cancers are high. You also have all cardiovascular diseases moderately increased in men with infertility, ischemic heart diseases, and mortality because of cardiovascular problems. The incidence of diabetes is also very high, and when Dr. Modi was talking about tail abnormalities, we find that if there are large number of men with ciliary problems, please rule out even diabetes in these men, because we have found a good association or a strong association. So we know that when there is male infertility, there are other problems to the health in this man. How does DFI translate to predictive odds for live birth? If the DFI is less than 20, we know that most of these men will not have any problem and they would be able to conceive spontaneously. When the DFI starts rising, goes up to 25, 9% of them would need some help, maybe a sperm wash or an IUI. But when the DFI definitely goes more than 30, a third of these men would require ART treatments. Can you offer them any help to repair this DNA damage? Yes, you can. There are 3 major antioxidants that can be used: the hypotaurine, the glutathione, and the CoQ10. So these are the 3 ones that can be used as antioxidants to help us to cause some amount of repair of this DNA. We know that paternal aging increases this ROS, and that is why antioxidants and mitochondria targeted CoQ10 should be included in the protocol for management of these. This is a very simple diagram which shows you which vitamin or which antioxidant works at which level, at the head, middle piece, or the tail. So then we conducted a study with 10 centers, each center giving us 30 cases, so 300 cases where the DFI was either raised or the counts were less than 15 million. And then we put them on a blend of nutraceuticals for 3 months. We didn't stop the treating doctors from offering them any treatment. Even if they achieved any ART pregnancies or spontaneous pregnancies, we requested that these men continue on these blend or on the corresponding tablets. And at the end of 90 days, we again measured their semen test and their DFI. And we found that in men in whom the counts were very low, responded best to the nutraceuticals, that is less than 5 million, responded more better than when the counts were marginally low. So your antioxidants work best in severe cases rather than mild or moderate cases. And there was almost a 20% drop in the DFI at the end of 90 days. And then we published this paper as impact of antioxidants in improving sperm parameters as a randomized, double-blind, placebo-controlled clinical trial. So, ladies and gentlemen, it is extremely important that counseling should be offered to couples, particularly with advanced paternal age, to explain to them that there is a low absolute risk that their ART treatment can be affected even with the paternal age, but more important is that there are severe de novo mutations and outcomes for the newborn or many adult onset diseases which are related to the paternal age. Thank you very much for a patient hearing. I would like to invite you to 2 conferences which you have. One which is starting from tomorrow in Bangalore, the South ISAR Regional Conference, 26, 27, 28 July, and the next international conference between ISAR and Aspire in Pune at the Westin, 2nd to 4th of August. Hope to see most of you there. Thank you very much.
Friends, you would agree that this was a masterly rendition of what paternal aging is to ART and to other things in life as such. So therefore, it's important, and the way Amit presented was extremely well documented, well presented, well studied as such. So if there are any questions, I would be happy to invite them here. This being an oration actually. Yeah,
No,
okay, no
okay.
questions, fine.
Comments?
Yeah.
We can make comments?
Yeah.
Can
You
we
can
make
take-
comments?
Yeah, you can take comments. Yes, sir.
Okay. What I was, how many people know what DFI means? Put up your hands. Amit, can you explain that, please? Because only 25% have put up their hands.
Yes, it is sperm DNA fragmentation index.
And what is the meaning of that index?
So it is calculated by the tunnel test, which is the most benchmark test. Unfortunately, the tunnel test is very expensive, very labile. So most of us do indirect testing, which is sperm chromatin we look at, and we see how much of it is fragmented, disturbed, and there's a way of calculating that. So you see for 100 sperms and you calculate it and you give a percentage of what is the DNA fragmentation in that sample.
So you're talking about the number of sperms out of 100 sperms, how many sperms show DNA fragmentation?
Increased fragmentation.
Yeah, and does the amount of fragmentation, DNA fragmentation in the sperm also matter?
Yes, so some amount of fragmentation will be there. Some amount of ROS is necessary for natural fertilization. But when the ratio goes higher, that is a time when problems come up. So some amount of it is necessary.
So when there is a sperm with DNA fragmentation and it is used for fertilization, if there's a small amount of fragmentation, the oocyte is able to correct it. It has the power to correct it. But if it exceeds a certain amount of fragmentation, the DNA, then the oocyte cannot take care of it, and then there is a failure of fertilization and repeat implantation failure, and blastocyst formation also fails, or progression fails, and repeated pregnancy losses are higher in patients with higher DNA fragmentation.
So nowadays, even in cases of recurrent pregnancy loss, one of the tests that we offer is sperm DNA fragmentation, in addition to doing the genetic karyotype.
So I like that picture of yours about menopause,
Yeah.
And I hope that
It will come up one day in Time magazine,
yeah,
don't worry.
we should send that picture to Time magazine, and perhaps they'll write something on it,
Andropause, yeah. Yeah, Mohan.
With, as we have egg freezing option, we should have sperm freezing option for
Correct.
all male.
Correct,
between 25
absolutely.
to 35 years.
Absolutely. But I didn't want to interfere in your panel, but my personal opinion is just because a technology is available, as fertility specialists, we should not be encouraging people to have children later in life. Every time we should be telling them that although your life expectancy has increased, especially in India, it has gone up now by almost 12 years. Unfortunately, your fertility window remains the same. So every time a couple comes to us, I know they come and they want to delay their pregnancies, but at the same time, at the end of the talk, you should always tell them that it is better that you get pregnant before. It is extremely important you have the children at the right time, because I think there is something called as the rights of the unborn child, which we don't look at. you and I as parents would want the best child to be born to us, the best in studies, academics, sports, everything. I think the child also has some expectations of what parents it wants. And I'm sure no child wants a parent who's 50 years old, arthritic, diabetic, and having lots of problems. So I think that is the importance. Couples come to us because they know a technology is there and they want to avail it. But I don't think we should be promoting it. We should be telling them, I mean, everybody has got career aspirations and everybody has got everything. But at the same time, as fertility specialist, I make it a point, even if they close their ears, from my side I tell them, you should be going for a pregnancy earlier than later. And I think then I have done my job. Then what they do beyond that is different. Same thing happens when they come for egg freezing. They unfortunately come when the battle is lost. The most of them, more than 80% that come to me are 38 and more. When I feel that, what egg are you talking about? What to freeze? So I think there is a something that the wrong group comes to us. The group of 25 and 30s don't come to us. The group of 40s come to us. So I think as fertility specialist, and I take this opportunity to tell everybody, please encourage your patients to get pregnant early. And I think they'll thank you, not now, but maybe 10, 20 years later. Yeah.
Can you give one take-home message for the advanced paternal age over 40? Should every man who comes for fertility treatment, and if he is over 40, irrespective of the age of his wife, should he undergo some
The problem
DNA?
with paternal aging, as I said, no, they're fertile, they don't come to you. The problem is that there are problems in the babies, and maybe now, then 40 years back, I didn't see so much of ADHD, I didn't see so much of autism. We see it now so commonly. So there is something going wrong in the genetic makeup somewhere. And maybe one of the reasons is advanced paternal age.
They are studying the effect of radiation from cell phones and from
Possible.
computers and all, and they are saying that is also a cause for increased incidence
Advanced
of ADHD.
maternal age comes to you, but advanced paternal age more often doesn't come to you.
Yeah, true.
Thank you.
Thanks so much. It was a wonderful session.
We'll have a group photo with, would like to have Deepak also on the stage to have a picture.
Dr. Desai, ma'am, we'd like you to be in the photograph, please.
I think we have come to the last part, and I think that is something that is very important for all of us. It is acknowledging our peers and our colleagues on this World IVF Day. I think the World IVF Day is the birth of Louis Brown, Joy Brown, because the fathers thought that she brought a lot of immense joy to the family. But it was something which was path-breaking, going against religion. The parents were ostracized, but still they managed to bring a joy, and millions of children are born with that technique world over in the last 46 years. We in India have had our pioneers, and we are very proud to say that the world's second IVF baby was with us. Unfortunately not well documented, but now recognized and acknowledged. But we also have some unsung heroes. And one of them, today we are very fortunate to have with us, Dr. Sadhana Desai. Dr. Sadhana Desai has been one of the pioneers in Mumbai. And when I spoke to my team at ISAR and I said we need to acknowledge and felicitate an IVF doctor, because I think this is not only a day for us to celebrate as IVF specialists, It is also for parents to celebrate this day because this is something that brought parenthood to millions of couples. The unanimous choice was Dr. Sadhana Desai. So I'm so glad, madam, despite all the Mumbai rains and you had an emergency surgery right at one end of Mumbai at Breach Candy, but you did come. So that just shows your passion to this field. And I've been a close observer for the last 30 years. And I know Dr. Sadhana Desai, along with her colleague, Dr. Meru Hansote, have faced immense trouble, right from making the medias, which she told me was such a big problem, to neighbors actually going to the police against them. Remember, Dr. Desai, in one of your sentences. So they have gone through a lot of hard work, and we are very fortunate that they paved the way for most of us to have a very easy practice. I don't know whether I would have continued in infertility if I had to get up at 3 in the morning and do an egg pickup, or make some 10 liters of media to use only 100 ml and throw off the 9 liters. So thank you, Dr. Desai, for setting the stage in India, and thank you for being with us. And I would really like to acknowledge your work and your passion. So on behalf of ISAR, I would like you to come up on the stage. The Indian Society of Assisted Reproduction recognizes the outstanding contribution of Dr. Sadhana Desai on the occasion of World IVF Day. We feel privileged to recognize your remarkable achievements, leadership, and compassion in the field of infertility treatment. Your work exemplifies excellence and innovation in the field of ART. Today on the World IVF Day, 25th July, Mumbai, signed by me as President of ISAR and Dr. Asha Bakshi as Honorary Secretary ISAR. So thank you very much, madam.
Dear Dr. Patki, the President of ISAR and the Managing Committee of ISAR, I am very touched and obliged to know that you have considered me to give this honor. I am highly honored. I must say that I have been associated with ISAR right from its inception till today, and I have seen ISAR grow and it expand. Many members now are there with ISAR. When I was there, there were hardly any members of ISAR. The ISAR is doing so much of academic activities. It is thanks to the younger generation. All the president does always better than the previous president, and therefore the whole society is expanding, and this is a very good thing. So many members are part of ISAR. I also want to say that I have been also fortunate enough to see the beginning of ART in India till today and see how technology has advanced. I had never dreamt that the ART technology will expand so much that now there will be era of artificial intelligence being introduced into the ART. But so many centers are there all over India, so many embryologists are there, but unfortunately, I only hope that ART remains with the academician, with the university, with the hospitals and private academician, and doesn't go in hands of entrepreneurs. ART should be part of medical treatment and not an industry, as many people call us. So I hope the younger generation will take this in the heart, because going in the hands of entrepreneurs will only exploit you all in the long run. Thank you very much for this honor.
I would also like to thank the 5 centers that have joined us in this live relay from Delhi, Varanasi, Chennai, Kolkata. 4 centers, okay. So thank you very much to all those doctors who are watching this live, and thank you to all of you who have taken the special effort to come down on this rather rainy Mumbai day to be with us. Thank you very much. Before we have the vote of thanks, I would like to invite Mr. Sudeep Mukherjee to please say a few words.
Thank you, sir. And thank you all to come down on this, in this wonderful day. We are celebrating World IVF Day, but nature was not with us today. So we didn't know that whether we will be able to conduct this program successfully or not. But at the end, yes, you are the messengers of God, so God was with us. So we could have 50 plus attendance even in this weather. I think that if we would have been a normal day, we would have attendance of 100. First of all, I'd like to thank ISAR for giving this opportunity to Mayor. Thank you, Amit Patki sir, that to come out with this wonderful idea of celebrating World IVF Day by discussing science. So this, as sir said, have been relayed across, along with Bombay, 4 other key locations, and I was getting the pictures and the messages from the other locations. It was a program which everybody appreciated, and once again, Mayor stands tall when it comes to innovation, when it comes to research, and with ISAR, it is like a family. Mayor and ISAR have always worked together in multiple incidences, in multiple projects, because we also, as Madam said, believe in science and technology. We believe to give the best to the fraternity. Thank you once again, sir, for giving this opportunity to Mayor Vitabiotics.
So coming to the official vote of thanks, I and my co-MOC Siddesh Iyer would like to thank ISAR and MOGS for coming up with this fantastic program under the mentorship of our ISAR President, Dr. Amit Patki sir. Special thanks to Sadhna Desai ma'am, a true guru to all the IVF practitioners, and as a youngster standing here, what a message ma'am today you gave it to us for next 3 or 4 decades for us to carry it forward. Thanks to our expert faculty, Dr. Pratik Tambe, Dr. Suchitra Pandit, Dr. Vanita Raut, Dr. Mohan Gadam, Dr. Rajkumar Shah, Dr. Sudha Tandon, Dr. Satish Tibrewala, Dr. Kedar Ganla, Dr. Deepak Modi, Dr. Amit Patki sir. Thank you for sharing your valuable insights and giving very crisp message to all the audience who's sitting here at our 4 satellite centers, as well as watching us online. Special thanks to our 4 state chapters of ISAR who are also simultaneously conducting the World IVF Day and had a live relay of Dr. Amit Patki's oration. We thank Delhi chapter, Varanasi, Kolkata and Chennai chapter. Last of all, a big thanks to our academic partners, mayors, without whom this would not have been possible. And most important, the august audience, you will always, always be appreciated for coming and listening to us. Thank you.
Also would like to thank Dr. Siddesh and Dr. Garima for taking the humongous task of coordinating not only Mumbai, but all our other 4, and to try and get the faculty for this program. Thank you very much.
Thank you, sir, for your...
We'll be now proceeding for the dinner.